Welcome, everyone. My name is Becky Sanders, and I'm the Program Director for the Upper Midwest Telehealth Resource Center. Thank you for joining us today for our webinar. Just a couple of housekeeping reminders as we get started. Our presenters have asked that we hold questions until the end. So if you want, as you're listening to today's presentation, you can use the Q&A button on the bottom to ask questions. You are all in listen-only mode for today's webinar. If you have any technical issues, please use the chat function for those technical issues, and Carolyn will assist you with those. We are recording today's session, and we will post it on our Facebook page. Or, I'm sorry, not on our Facebook page, on our YouTube page, and also on the archive webinars portion of our website, where we will also have the PowerPoint slides. I think that's it, and I'm going to go ahead and introduce our presenters today. To me, they need no introduction. I've worked with both Alli Flowers and Amanda Bohleber for several years on several different projects, and I'm excited to hear from them today. They've had resounding success with their RPM program, and look forward to picking up any little tidbits that we can. Ladies? You are muted still.
Can you hear me?
Yes. Now
okay, perfect. And you can see our screen?
Absolutely, yes. Looks
okay.
perfect.
All right. Well, we can go ahead.
Yeah, we'll start. Yep, so we'll go ahead and just introduce ourselves. My name is Amanda Bohleber. I'm a family physician. I've been in family practice for 16 years here at Deaconess. I still practice and see patients actively. I've been in the role, we've been doing telemedicine together since about 2015. And so I served the health system since 2018 as the Chief Transformation Officer, do a lot of primary care redesign, and work directly with Alli on all of our telemedicine programming.
And I'm Alli Flowers. I'm a nurse by background, and most of my experience is in cardiac ICU, some home health, and as Dr. Bohleber said, we started down this road in 2015 and really have expanded a lot of our programs within the health system. It's been really exciting. So remote monitoring has been our baby for a few years, I guess almost 3 years now in October. So we're excited to share some information with you.
All right. So we'll tell you a little bit about Deaconess Health System, just an overview. We are a 10-hospital system, and we're located in southwestern Indiana. We do serve about 26 counties in southwestern Indiana, southeastern Illinois, and western Kentucky. So we are a not-for-profit health system, and we are run by a local board of directors, and we've been in business for well over 125 years. And we are the leading tertiary provider in our region, where about 2 out of 3 patients in our area choose Deaconess for their care. So for today's agenda, we're going to start with our challenges. We faced several of them, but those challenges really inspired the vision that we had to improve specifically remote patient monitoring at Deaconess. So then we'll share specifics about the goals that we have for the program and share with you our journey from the very beginning to how we got to where we're at today. And then we'll finish by sharing a lot of our outcomes to date. We'll get right into the details and share those with you. And then we'll also end with some of the lessons we learned over the course of the journey. So when Alli and I decided that we wanted to really enhance our remote patient monitoring program at Deaconess, we were facing a lot of challenges. So our readmission rate at the time was in the upper 20s, often 25 to 29% each month for those CMS cohorts that you receive penalties for. And so with rates that high, we actually were facing $1 million penalties year after year for our really a poor performance on readmission rates for those cohorts. So at the time, we were doing remote patient monitoring, but we had a legacy program that really had, I guess what we're describing as legacy is really the equipment. It didn't really offer state-of-the-art data extraction. And instead, we were really doing our best to track the outcomes manually through spreadsheets, doing that data by hand, and it was not getting us very far. So as a result, we really didn't have what we needed to properly communicate the outcomes for a good return on investment for the program. And we also, at that time, were not using any tools or data to really help us identify who is the right patient, who's going to benefit most from the program. So at that point, we had a lot stacked against us. So when we presented to our executive team, they were very much divided on whether or not to give us a second shot, whether or not they would support a pilot program with new equipment. So Alli and I at the time were really passionate about getting another chance. We wanted to do this again. We knew it had anecdotal success. We had seen some patients really change their lives. And thankfully, the health system was willing to support us, and they gave us another opportunity. They actually gave us 12 months to prove that our program would be helpful. So we took our challenges, and that's what we used to set our goals for the program. So we aimed to reduce, like everybody else, reduce those readmissions for the CHF and COPD cohorts specifically, and lower them enough that we could avoid the CMS readmission penalties. So we committed to collecting the data that we needed to really measure the program's return on investment for the health system. So we wanted to see how we could impact the readmission, not only just the all readmissions, but specifically that 30-day readmission rate. We also wanted to look at what patient populations were going to benefit. So we wanted to look at the data by cohort, so separating the CHF, COPD, we're looking at diabetes, CKD, hypertension, and our pneumonia patients, and any combinations of those diagnoses as well. Then we wanted to look at, we started using a tool in Epic, our electronic health record that measures and predicts readmission risk. So we wanted to use our data to help prove and identify if that tool was valid. So test the validity of the readmission risk predictive model in our electronic health record. We also wanted to see how the program impacted ED visits. So we know that RPM a lot of times will drive ED visits up. So we wanted to see and make sure, are we consistent with that? Are we above the benchmark, or can we really reduce ED visits? And then we also wanted to look at the total cost of care. So does the program really make an impact? Does it reduce the total cost of care spent on those patients from a payer perspective? So are we really saving money for population health and for the payers on these patients? And at a minimum, we really hope that we could at least break even on the program and gain some system support so that we could grow the program.
Okay. So let's look at how our program journey has gone along. So how did we get started? How did we build and automate our processes? And then how did we scale and sustain our program? So I'm going to start by sharing, I know Dr. Bohleber gave a little bit of background about our previous program, but it lived in a home care agency. We really were not involved with that program at all. And it had been active for approximately 10 years when the equipment aged out and it no longer functioned. So we went without a program in our health system for almost a year and a half before we started investigating or looking at this opportunity again. So we started by looking at the literature review, and like Dr. Bohleber said, it varied across the board if it worked or not. But the outcomes that we felt, the programs that were not successful, they were not targeting the right population. So that's where we really wanted to focus. We decided to move forward with equipment demos and created a pro forma and presented that to our leadership team, and really just wanted to gain support for that new program design. So our redesigned program, we would target patients with chronic conditions that were high risk for readmission. We selected a vendor that had modern features, easy deployment, it's easy for the patient to use, it has an intuitive dashboard, and you can efficiently triage patients, so it makes it easier for the RN, and in-depth reporting features and worry-free logistics, which that is it's really nice to talk about the logistics for a minute. With our program before, for 10 years, our nurses were picking up kits, delivering to them home, cleaning them, doing all of that work. Nothing was automated. And the logistics for this, everything goes to one center, they clean it, get it ready for the next patient, ship it to the patient. That all happens through FedEx. And then when the patient's done, FedEx picks up the kit. So it really makes things a lot easier and less work for our nurses to have that automated. Our kits contain a video-enabled tablet with cellular connectivity, a blood pressure monitor, scale, and pulse oximeter, and they're all Bluetooth connected to the tablet. So on arrival to the patient's home, they open the box, turn the tablet on, and they're ready to go. I want to point out that it is okay to start small. So our program started with 1 nurse and 50 kits. And currently, just even at almost the 3-year mark, we now have 2 nurses and 70 kits. So it's expanded just a little bit. So how can we select appropriate patients? We target patients with chronic conditions such as CHF, COPD, diabetes, and chronic kidney disease. We focused on populations with readmission penalty fees and higher rates of readmission. So our medical record has the proprietary readmission risk tool. So we focused on patients that were greater than 20% for readmission. The RN completes an in-depth chart review for each referral to ensure the patient is appropriate for RPM. And we always say this, RPM is not the kitchen sink, and there are certain criteria that will eliminate your patients from participation. And we can go into more detail with that after the presentation. I think that raised a lot of questions when we've talked about this before, and who's appropriate, who's not appropriate. So after the chart review, the RN contacts each patient to introduce the program and make sure they're agreeable to participate. And we are open Monday through Friday. So if they call after hours or weekends or holidays when we are not here, they actually get rolled over to our 24/7 nurse triage, and then they can provide support, let the patient, help them make a decision on the appropriate level of care if they even need care. To determine the needs that your organization needs, just consider, what is your why? What is an opportunity at your organization that RPM could improve or resolve? So we do bill for remote patient monitoring, and we bill the following CPT codes that are listed out: the 99457, 458, 453, and 454. So the professional fee, initial kit setup, and then, the initial education, and then the kit rental per month. So the RN summarizes the monthly progress in a note and submits the ordering provider for co-signature in the medical record. So they basically copy a summary out of Vivify, which that's the company that we partnered with, and they copy that over into Epic. We make sure to include how much time we spent with a patient, and that we have a consent documented, just the basic criteria that is needed to be able to bill for the program. We also have the last visit with that provider, since they have to be established with that provider to participate in the program. If there are any issues that come up, so we communicate all of that in our medical record or by phone. If it's something that really needs to be addressed, within the next hour, we will call and send a message in Epic. And then the provider can actually set specific parameters for each patient. So it doesn't have to be across the board, notify me of this blood pressure for every patient. If they typically run high or low, then we can set those parameters specific for each person. Okay. So we do have the option to enroll a patient into 2 different programs. We actually have the home and plus go options. The home program is the one that comes with a full kit, and that's the program that we use to target our chronic condition patients. We went live with that in October of 2018. And then we launched the Plus Go program. That is rather new to us, I would say. During the second wave of COVID in October of last year, We were able to monitor a little over 400 patients, and basically the patient checks in using their own phone, and our foundation purchased pulse oximeters, so anybody that was in the emergency room or admitted, we could send them home with a free pulse ox, and then they could check in just using an app on their phone, which was really a lifesaver when we had our emergency rooms overflowing with patients. So identifying your referral sources is key to enrolling the right patients in the program. A majority of our referrals come from an inpatient stay. We do have CHF and COPD navigators at Gateway and Midtown, so our two larger hospitals. Our case managers and hospitalists identify patients for the program as well. So we receive a monthly list from our ER, and it's what we would say a high utilizer list, so patients that are frequently visiting the emergency department that month. And we just pull out those new patients that hit that list to see if they're appropriate for the program. We are part of an ACO, and we receive a daily list of our ACO discharges that have chronic conditions, so we can reach out to those patients as well and see if they're appropriate. Maintaining good relationships with your referral sources is important, and sharing outcomes with the groups to get buy-in for the program is really key. When we presented to the hospitalists, that was their big question. You know, how many patients that are referred are being accepted into the program, and what are your 30-day readmission rates, total readmission rates? You know, they really wanted that amount of detail, so we actually share that monthly with them now so they can review that information. COVID, of course, created a shift in our program, and in the fall of 2020, when that second wave struck, we were able to rapidly expand and added the Plus Go program, which was really nice. So we did monitor over 400 patients that were either discharged from home or the emergency department, and it was just a lot easier to send them home with a pulse ox and an app, and we could immediately start monitoring. So they weren't waiting for a kit to be shipped to their home, which is a plus, you know, for that bring your own device type program. Patient care and education is another key to a successful program. So the nurses focus on educating the patient on their chronic conditions. They teach them who to call when something is wrong. And that's really important, because when they have several providers, you know, that they have two specialists, a primary care, and, you know, whoever else they're seeing, they don't know who to call when something's wrong. So the RN empowers the patient to self-manage their conditions, and they connect patients with community resources and help solve for healthcare disparities. We have a whole list of programs and community resources that we refer our patients to, you know, whether they need help with groceries, they need help with transportation, if they need home health therapy, lots of things that we're prompted to ask the provider for referrals on, or just refer them to the community resources. They focus on compliance with care, such as medications, appointments, diet, and self-monitoring. And then we do have the after-hours support that I mentioned earlier, but it's important to know that we rarely get a call after hours, because the nurses are really good about preparing the patient for after hours and weekends. So they're asking them, you know, starting on Thursday, do you have all your medications? Do you have everything you need to get you through the weekend, and make sure they're prepared going into holiday weekends as well. But the end goal is to get the patient to graduate from the program and become more confident and comfortable in managing their care. I think our nurses that we have, they really have a passion for building relationships and educating our patients. They have diverse backgrounds, which is also important, and they can help each other. So as nurses, you know, they specialize in different areas. So we have one that really has a specialty in cardiac patients, one with kidney patients, and one has more of an overall med-surg background. So they can really help each other with that piece when they need it. But they're definitely the glue that holds the program together. Vivify offers an in-depth reporting option, and it simplifies data collection and reporting. So a monthly dashboard is created with data extracted from Vivify and Epic. And so we're going to look at some data on these next few slides. So to create this data dashboard that you're looking at, this is the first page of our dashboard. We worked with one of our data analysts, and she helped identify data points that we needed from the medical record and Vivify to create this, to be able to look at our progress each month. And it took, I'm thinking like 6-ish months to get it to where we wanted it, and we still add. So if we identify things that we think would be useful, then we just reach out to her and she helps us figure out how we can collect that information. So the highlights on this slide, since October of 2018, we've monitored 379 unique patients, and our 30-day readmission rate as of July 1st is 5.41%. So the blue, yellow, and green bar graph right in the middle, which I don't know if you can see my mouse, but right here, that is showing our risk for readmission. So we keep mentioning that we track and monitor our total risk for readmission and taking those patients into the program. So blue is a greater than 20% risk for readmission. Yellow is the 10 to 19 range, and then green is 0 to 9. So we don't have a lot of patients in the 0 to 9 range, but there are some. I have a feeling a lot of the patients in the green range are the COVID patients that probably were in the emergency room and then just went home, you know, for the plus go monitoring. Almost 50% of our population is traditional Medicare, so that's important too. And our patient satisfaction shows the would recommend score is 96%, and they mostly, 95% of them feel the technology is easy to use. So if we look at our ED total readmissions and 30-day readmissions, we compare 180 days before and 180 days after they start the program. So since October of 2018, there are 200 participants that meet that criteria. And in the past, we have really not impacted our ED visits at all. But once we started monitoring COVID patients, we actually are down 74 total ED visits within that time frame. So you can tell, I mean, just that alone, I think, shows how much those patients were going into the emergency room, which is really interesting data to see. Prior to this, we were always in the red, I would say, and around, it wasn't huge, but maybe 5 more visits, you know, after they were out of the program. But one thing that we have benchmarked with other programs, they see the same type of data and feel like the patients are seeking treatment sooner, so they're able to be treated and then sent home and they're not admitted. So our total readmissions are down by 243 or 53%, and 30-day readmissions are down by 133 or 49%. And then the change in claims dollars, which include both hospital and professional billing, are down by 8.3 million. So we're down 6.2 million for our non-ACO population and a little over 2 million for our ACO population. So that is this section right here at the bottom, where we look at what were the total claims 180 days before and then 180 days after the program. That's important for all your payers because they like to know what their savings is or total cost of care after they're in the program. So we slice the data in several ways, and Dr. Bohleber again mentioned this in the beginning. We wanted to look at how does it break out for each group. And we continue to have consistent outcomes, which we find really interesting. We break down the volume differences based on the RPM program. So total readmissions and 30-day readmissions reduced consistently in all programs that included CHF. When looking at the claims data, we have the biggest reduction in the total cost of care with our greater than 20% readmission risk score, which is also interesting and why we are so focused on that population. We see a consistent reduction in total cost of care across all payers. Chronic kidney disease, they are our interesting group. So chronic kidney disease with comorbidities they rarely benefit from the program. We are hoping to change that with the addition of our newest nurse who has background with CKD patients and potentially a new provider that has really taken an interest in this as well, to be a leader on the provider side. So an example is the CHF diabetic and CKD program. The average hours spent with that population is very high, and then the total cost of care actually increased 180 days after the program. So the data slides we reviewed include our total RPM population. We also track on a separate dashboard the patients that are referred to us from the emergency department because they wanted to see specifically what their referrals look like, you know, before and after starting the program. And we also track our ACO population on a separate dashboard. Back to you.
Yeah, so I'll go over just to summarize. I think it's important to pull out some of the outcomes that we have for the program. So again, Alli mentioned we've had to date through July 1st, 379 of our chronic condition program participants. She mentioned earlier 400 patients during the COVID peak in October of last year. Was 400 participants for that program. Our 30-day readmission rate, again, at 5.41%, we've really slashed it in half. So it's been an exceptional. It's really the bright spot that we hold our breath every month, and it continues to remain low. So that's always been real exciting. And then just we share the $8.3 million reduction in total cost of care, and we realize that revenue is actually revenue that our health system loses. So those patients would be coming back into our hospital. But more importantly, what we're avoiding is close to $800,000 in readmission penalties. So that's really a savings to the health system. And what we do is we use that $8.3 million to talk to our payers. And we do have a mixed bag, and I'm sure some of you experience this who run remote patient monitoring programs, that there's not always good reimbursement for billing for this program, and so you really have to commit to doing it, and our to pay for it really is what are we getting back with avoiding those readmission penalties. So for us, it's about $800,000 to date. We also, for the inpatient stays, have avoided $640,000. So if you think about those patients coming in to the hospital that otherwise would have been readmitted in that 30-day window, we would have spent $640,000 on those patients and not been paid for those readmissions. So adding the two together, it's $1.4 million that we feel like is true savings for our health system. And then we always like to spotlight, any program, we have to have patient satisfaction. Their satisfaction is key for us across the health system. So this program in particular is another bright spot with 95% patient satisfaction. And again, just to highlight, we talk about the specifics of who's a good patient for the program. It's those with that 20% risk of readmission or greater that we see the greatest cost reduction. So trying to achieve the goal of validating the readmission risk tool that we're using, the EPIC, we do feel like it's a very valid tool for us. And as far as program enhancements, we continue to work on enhancing this program as well. We are actively participating in multiple inpatient teams, so we always want to have the RPM at the table when we're discussing any sort of strategy and using RPM, remote patient monitoring, whenever it's appropriate and when patients would benefit from being monitored. We do maintain a very good working and close relationship with the navigators that are in our health system for CHF and COPD, and we're helping the chronic kidney disease service line advocate for getting a navigator as well, because we've seen these other benefits on the CHF and COPD side. So we've leveraged our EMR as well by hardwiring a referral to RPM on our CHF and COPD discharge orders, so that it's always prompted at discharge to consider enrolling the patient in the program. And then we've added a flag in our health system on the chart, so it appears in EPIC to alert an emergency room provider or a case manager that when one of our RPM patients shows up in the facility, that just to know that they're enrolled in the program, because it can make a big decision in whether or not they can safely be discharged to home. If they know they have the monitoring program, they're going to be more inclined to send that patient home. And for the operational leaders who are really on the call today, We've added a productivity index model that helps inform us when we need to consider that we need to add more kits or add more staff to expand our program. And lastly, just some lessons learned. Again, we can't say it enough that remote patient monitoring is not the kitchen sink. When we started, everybody sent us the patients that they could never keep out of the hospital. And it was because they had some of the problems that RPM is not necessarily the solution for. But there are definitely patients who do fit for the program best, and having some clear guidelines like readmission risk tools can help you identify the patients that fit your program best. So tools to identify the right patients is vital and will guide you in making sure that you're hitting on all of your goals that you've set for your program, and really developing a patient-friendly equipment, picking your vendor, and thinking about what would it be like for a patient to use this at home, recently discharged. It's going to impact how your program performs and the adherence, so you need to be sure that that's part of your evaluation. And then platform dashboards and reporting really have been a game changer for us, and they're real crucial in your ability to communicate just with your stakeholders, those who are making referrals, and then also communicate the return on investment. But it also directs your program to where areas that you can make the biggest impact, and also how to keep your staff efficient when they're working in the program. So we want our RNs really doing a lot of patient care time and not working with a platform that's burdensome. And lastly, we constantly try to promote our program with the key stakeholders, and again, being at every table to tell our story, and also continue to identify any new population where the program can be of benefit. So we will stop there. That's all the slides we have for the group, but we'd love to open it up to question and answer.
So Becky, you want me to stop sharing here?
Yes, if you would, please go ahead and stop sharing. Thank you guys for an excellent presentation. As we're waiting on questions to come from the audience, I just wanted to highlight just a couple of things. So I noticed that you really focused on those top 3 diagnoses, the CHF, COPD, and diabetes. And then, so then you added that chronic kidney disease where you're having a little bit of issue and looking for the right provider to work with those patients. What prompted you to work with kidney disease?
So we feel like right now we are not penalized for those readmissions, but they're on the radar that eventually or soon we will be penalized for those. So we're trying to come up with something that can help with their readmissions as well. And I think that, CKD is frequently a comorbidity of our heart failure patients. And so we want to call that out and see, is there a difference in our success rate and the way the program impacts patients with both heart failure and CKD? I think, as Alli pointed out, the provider support is important. Right now, our nephrology group is really covered up. They've got lots of dialysis patients, and they're more focused on acute care. And so we're looking at, a provider in nephrology to add to our program that is more focused on keeping patients at home, and even have talked about palliative care as an option to help with that CKD patient. So we're just venturing out to see, what are our issues, how can we improve? So we continue to spotlight, because that could be a difference maker. And if we didn't identify them as a CKD patient, we may not understand, kind of how our program's operating.
When you mentioned that you had to kind of go back to the drawing board at one point and kind of start over again, what were some of those crucial conversations that you had with the executive leadership at Deaconess? How did those go?
So, I feel like what we decided to do was just gather up as much information as we could. So that's why we did the literature review, what's out there, what programs have been successful, and we wanted to see who hasn't been successful and then try to figure out why that was. And even the program that we had before, that went for 10 years, it lived in the home health department. They weren't real specific on who is appropriate, who isn't. It was just, hey, you need your blood pressure monitored, we're going to give you a kit. So they weren't, you know, they didn't, I wouldn't say had a real goal in mind. It was just an enhancement to the home health agency. So we put that all together and then try to figure out how can we make this work and make it effective and have good outcomes. We put a whole presentation together. We had our pro forma, and then we presented to our leadership group at one of their, it's a biweekly meeting actually. And like Dr. Bohleber said, it was torn. They were about 50-50 on if they wanted to let us move forward, and they decided we could do a 12-month pilot. So that's how it started for us, and we've been lucky to have good outcomes.
Mm-hmm. And do you have, so in telehealth, we talk about having champions. So you guys are obviously two huge champions for the program. Did you have any naysayers that later became champions?
So, I mean, our CEO was right there saying, I don't think this is going to work. And now he completely sees the value. We had, we've had some physicians that initially, say a hospitalist service, that were reluctant. But once we were able to get the data out and say, look, this readmission risk score is right there on your daily dashboard. So they're rounding in the hospital, getting ready to discharge the patient. They can see the risk, and we can show them the data saying we can keep this patient from coming back in the hospital. And that's where they really kind of got bought in, I think, is once we showed them that our program worked, because they had the anecdotal experience previously, that regardless of what they were doing, they just didn't know what the impact was. So definitely now we've seen a bigger shift. And so recently we've kind of tracked our referrals, and back to one of our initial dashboard slides, you can see the referrals start to accelerate. And that's when the hospitalists, they saw the data and they said, yeah, you guys really are making a difference. And as a health system, we have strategic goals, and one of them specifically was around this heart failure readmission. And so all of us actually are tied to that incentive goal. And so everybody wants to pitch in, and we said, listen, hospitalists, cardiologists, you're the primary driver here when these patients go home, and our program can help reach that goal. And so again, it just really accelerated. And then the more patients that they see discharge safely and remain out of the hospital and quit circling back, they start to buy in, and then they get their friends to refer. And that's when we said, okay, we need more RNs, we're going to need more kits. But I still feel like we're still kind of small, because we've found our niche, but that doesn't mean that we're not going to continue to evaluate even how do we keep patients from ending up being that patient that continues to come back in the hospital. So what are those high-risk groups ambulatory that are frequenting the doctor's office with exacerbations that could benefit from maybe a plus-go model? Maybe it's not a full kit, but maybe it's more regular check-ins and education about their disease process that can help them end up not becoming a patient that's frequently hospitalized.
Absolutely. Is there something in particular, I'm trying to look at the questions as they come in here, something that was part of the standard kidney disease program that was not effective, or something that you're looking to add to that to make it more effective?
So I think originally we've only had, it's a rare, a really low number. I would say a handful of patients that were strictly CKD. Most of them are in that, like Dr. Bohleber said, CKD, CHF population. The ones that, it's our dialysis population that is the hardest to impact. I think for the ones who are just in, stage 2 or 3, pre-dialysis, anybody that's a pre-dialysis patient, they're easier to manage. They just are. Once they are in that dialysis group, they are more difficult to manage. And there were a lot of barriers. Transportation is a huge barrier for those patients. We would even help facilitate transportation to get to dialysis, and we would call them to make sure they were going, and they would say they just don't feel well to go. And we say that's why you should go, it will help you feel better. They still wouldn't go, and then they would end up back in the emergency room for emergency dialysis. So, we're hopeful if we can get the right physician to help us lead that charge, that we would be able to make an impact on that group. I think that it's a tricky population.
It is. And there's a question about CGMs for diabetes. Do you guys have a standard protocol as far as, which vendor you use and what kind of software to check up on the blood sugars and stuff?
So we don't, actually, that's a great question. We do have pharmacists that really operate our CGM on the outpatient. They work directly with our endocrinologists. We are not using, I think CGM is not necessarily incorporated in our remote patient monitoring model. We really have the patients just record certain fasting recordings or readings for that day and input them. So they're separate. It's not a specific component of a kit or a certain pathway that we would send with a patient that's being discharged with diabetes. So it would be nice if it had one of those. Maybe that's an enhancement. And I'd be curious if whoever submitted that question, if they could elaborate more. Perhaps they're in a program where they've got kits that have those integrated, because we'd love to learn from that individual.
And I think the reason we didn't do the glucometers in the kit, we did discuss that, but the patients are used to what they have at home. So we want them to be comfortable with that, and we didn't want to switch them to something different. And we looked at, so there were other vendors that we looked at, and they said, they had adapters that would make different glucometers Bluetooth, if they weren't
compatible.
Yes.
Yeah.
And there was a list. Well, it really wasn't a list that included a lot of the glucometers that our patients had. So we just decided if they're diabetic, they have a glucometer, they can use their own to enter in that information. And that's kind of where we landed with that. But they do have them, that is an option.
Yeah, I just now noticed who submitted that question, and I can certainly connect you guys.
Good.
From my perspective, I have a daughter who's type 1. So I know you guys said that this was just strictly Medicare patients. So you'd be dealing with type 2. But whenever we go to my daughter's endocrinologist, and I know there's a lot of different vendors, and we stay vendor neutral as much as possible here. The CGM that she wears has an app on it that they can pull up. We've allowed the office to see that. So when she goes in, and it's usually like every other visit, every 3 months, one will be in person, then it'll be telehealth and back and forth whenever she has to get labs drawn, but they can see those trends in her data.
That's
really
interesting.
I know exactly what you're talking about, and our endocrinologists do that. They set those up. And actually, back to, I just want to clarify the comment about Medicare patients. I think Alli mentioned that about half of our patients in the program are Medicare, but we take patients, all payers.
Okay.
So we're really focused on, first and foremost, their readmission risk and their comorbidity, and recently being discharged from the hospital, but we are payer agnostic. I mean, we will take any patient. We will bill any and all insurance. Whether we get paid is hit or miss. But at this point, we feel like there's so many other benefits that we're willing to take that. We find that a lot of people are not billing because it is complex. There are some rules. I think because we have to have a Deaconess physician for that patient, we're very blessed that we have an extensive primary care base, upwards of 500 physicians as well as specialists. So we can oftentimes have patients that have a Deaconess physician. So we do bill because we want payers to learn more about RPM, and you can't get these codes paid for if you don't bill them. So we do go through that process, but it adds time to what our RNs do and their workload. We've seen other programs that can have RNs staffing kind of a workload of upwards of 60 patients. Ours are more closer to 40 because our RNs are also doing the referral reviews. So they're identifying, you know, is this a good case? Is this a good patient that would fit? And then they also go and do all the documentation that gets sent to the provider for review and for billing. So it does reduce their ability to monitor more patients. But again, we want to advocate and try to get better reimbursement so that more patients will end up being able to benefit from remote patient monitoring. So we're willing to take that into consideration and do that extra work.
Very good. Yeah, just a couple of different thoughts. I know you guys have been kind of on the national circuit. I've seen some national news stories about your program and the savings. So I want to congratulate you on everything that you guys have accomplished. You guys are really setting the trends in this area. Have you guys thought about publishing in a peer-reviewed journal?
So originally, when we started this, we wanted to make it an official study. We wanted to get 2 arms because there was so much data out there that said, you know, RPM doesn't necessarily make a difference. We couldn't get enough principal investigators from our cardiology group to help with that. Now that we have it running, we could do that. Right now, we're probably like every other health system. We're running pretty lean just to keep our program going. We don't have a lot of extra time to do the study. Sometimes in the summer, because we're in Southern Indiana, we're affiliated and have good relationships with IU School of Medicine, and a lot of times they'll get some of those med students with us, and they're eager to help put in the work and pull that data together. It's on our radar, and I wish that we could have done that. And at some point, hopefully we'll be able to contribute to that growing knowledge base and be able to do a true, you know, controlled study to get published.
That's great. We also had another attendee share, and thank you for sharing, Mitzi, that she's a type 1 diabetic and that she has been working with her CGM output with her clinical pharmacist and has been able to tweak her insulin pump settings and has gone from an A1C of 9.4 to 7. And that's awesome. So congratulations to you.
I was thinking the same thing. I read that. Congratulations.
Yeah.
And I saw the question, Becky, what vendor do we use? We use Vivify. It's Vivify. And we did look at several different vendors when we were making that decision. So it's always good to look at, you know, we went with them because of their reporting, the logistics, and really the dashboard is so user-friendly for the nursing staff as well. And it's easy for the patients.
Yeah, I've heard a lot of good things about Vivify. I worked with some folks at University of Southern Indiana, and I think they worked with you guys to figure out what equipment that they wanted to use for their students there. And they ended up getting Vivify stuff and also Tyto home stuff. So those are 2 vendors that I know are really advancing care as far as solutions that can be used for remote patient monitoring, but put into the home that are lower cost for the patients to make it possible for you guys to do the work that you're doing.
And I think when you think about vendors, maybe we didn't emphasize enough in thinking about the telehealth space that having something that's video enabled. So what was nice is that we didn't have to worry about the patient having bandwidth or Wi-Fi because the device itself was video enabled, and it was so simple to, if we needed to do a video visit, and the RN could even escalate it to myself as a provider, and I can do a video visit with that patient. So it just has kind of that dual function, which was extremely helpful, and we didn't realize how helpful it would be until we got into the pandemic and have been riding the coattails of telehealth explosion across the country. And now I think we're all just trying to settle in and figure out, now we've seen so many people use it, where's the right fit? the best balance of in-person versus video, and still just trying to explore that and excited to see where we're going to end up next.
Absolutely. I'm going to last call for questions. I think there's one more. No, I guess not. So we did answer that. I'm going to ask Carolyn to go ahead and put the survey in the chat. And for our attendees today, because we are federally funded, we like to be able to give feedback to our funder and to give also feedback to our presenters today on their presentation. I want to thank you both again so much for being with us today and presenting this valuable information.
Thank you
Thanks
for
for
having
having
us, Becky.
All right, everyone have a great rest of your day and a great weekend.
You too.
Have a good weekend.